Investigating dysphagia involves a systematic approach to determine its underlying cause and assess its severity. Dysphagia, or difficulty swallowing, can result from various conditions affecting the mouth, throat, esophagus, or nervous system. Here's an outline of the investigative process. 1. Clinical history. Onset and duration. Sudden or gradual onset, and how long the symptoms have persisted. Nature of difficulty. Oropharyngeal dysphagia. Difficulty initiating swallowing, choking, coughing, or nasal regurgitation. Esophageal dysphagia, sensation of food sticking in the chest. Associated symptoms: weight loss, odynophagia, painful swallowing, regurgitation, heartburn, or hoarseness. Triggers: solids, liquids, or both. Risk factors: smoking, alcohol use, recent surgeries, neurological conditions, or radiation therapy. Medication history: medications causing dry mouth or esophageal injury, comorbid conditions, neurological disorders, gastroesophageal reflux disease, GERD, or connective tissue diseases. 2. Physical examination. General assessment: signs of malnutrition, dehydration, or respiratory compromise. Oral cavity and throat: look for structural abnormalities, lesions, or masses. Neurological examination: assess for cranial nerve dysfunction, motor deficits, or signs of a central nervous system disorder. Neck examination: check for masses or thyroid enlargement. Chest examination: evaluate for signs of aspiration or associated respiratory complications. 3. Initial investigations, blood tests, complete blood count (CBC) to check for anemia or infection. Thyroid function tests if thyroid involvement is suspected. Chest X-ray: rule out mediastinal masses or aspiration pneumonia. 4. Specialized diagnostic tests. Barium swallow esophagram evaluates structural abnormalities, e.g. strictures, rings, diverticula, and motility disorders. Upper endoscopy esophagogastroduodenoscopy, EGD, identifies mucosal lesions, strictures, or tumors in the esophagus and stomach. Esophageal manometry measures esophageal motility and identifies disorders like achalasia or diffuse esophageal spasm. Video fluoroscopic swallow study, VFSS, assesses oropharyngeal swallowing mechanics and aspiration risk. pH monitoring evaluates GERD if suspected. 5. Advanced imaging, CT or MRI, for structural abnormalities or masses in the neck, mediastinum, or brain. Endoscopic ultrasound, EUS, if a mass or malignancy is suspected. PET-CT for staging if cancer is detected. 6. Multidisciplinary involvement. Speech and language therapist SLT assists in evaluating swallowing mechanics and recommending swallowing therapy. Dietitian provides guidance on maintaining nutrition and hydration. Neurologist if a neurological cause is suspected. Gastroenterologist or NT specialist, depending on the findings. 7. Treatment and follow-up. Address the underlying cause, e.g. dilation of strictures, treatment of GERD, or surgery for malignancy. Provide dietary modifications or swallowing therapy as needed. Regular follow-up to monitor progress and prevent complications like aspiration pneumonia. This structured approach ensures a thorough assessment of dysphagia and guides appropriate management.